So good evening. I think we'll start with the little introduction. So during the last participants coming in, we'll give them some time. A very warm welcome from the section of neuro-oncology of the EANS, and on behalf of the section speaker, Matthias Simon, it's my pleasure to welcome you to this webinar. The focus today will be on H3k27 or H3 mutated gliomas in adults, and we have two magnificent speakers for that. We will have a short discussion right after each talk, so please use the Q&A section of the webinar, and we'll try to accommodate all questions arising, and then we might have a little discussion also with both speakers together after both talks. So it's my great pleasure to introduce Malte Mohme from Hamburg, Germany. Malte did his medical education in Hamburg, also his doctoral thesis focusing on T-cell biology in multiple sclerosis. Additionally to that, and his residency in neurosurgery also in Hamburg, he had research fellowships at Johns Hopkins, Zurich, and Duke University. After his residency, he's now head of the research group of tumor immunology with focus on T-cell biology in malignant brain tumors. And clinically, he's a consultant in the University Hospital of Hamburg. He will talk about new insights from a multi-center study on K27 mutated gliomas. Thank you, Malte, for talking to us.
Thank you, Christian, for the introduction. Hello, everybody. I'm happy to share with you our data from the multi-center study. So I have no conflicts of interest. And as a short introduction, I think most of you know about this kind of entity. The K27M mutated glioma are actually a grade 4 tumor entity. And the overall survival ranges in the area of glioblastoma, with sometimes even being more aggressive. Since 2016, the new WHO classification system has characterized them as a separate tumor entity. And the K27M mutated glioma are often also called diffuse midline gliomas, although in this study, we pretty much just adhere to the molecular characterization. I'll talk to you about that later. So the tumors are characterized by the presence of a lysine to methionine histone modification at position 27, and you can diagnose that with immunohistochemistry, with a special antibody, or with a certain molecular pathology techniques such as the methylation arrays. The tumors are usually have a higher prevalence in children, where they represent over 20% of all pediatric CNS tumors. In adults, it's still unclear because they are rare, and the data in adults is quite scarce. So what we did in Germany, and together with also Innsbruck, München, Freiburg, Heidelberg, Mainz, Münster, and Berlin, we collected 70 adult patients that between 2016 and 2022. The inclusion criteria was an age above 18, although this can be discussed if there's a clear cut. Right now, we only focused on the tumors above 18 years, and we selected them for the positive for the immunohistochemistry or other methods. Overall, we collected perioperative patient data and something that was specific for the treatment in a surgical way, and then we analyzed that impact on the overall progression-free survival and overall survival. So the median age was around 36 years, as you can see. There is also a group with a prevalence in the higher ages, around 50 to 60 years. So it's not a tumor that is only confined to patients below 40 or 45, so it has a certain age distribution. If we look at the localization, we have to say it's a very heterogeneous tumor. So while most of the tumors were located somewhere in the diencephalon, We also see some tumors located above or below. And it was quite interesting that there's a certain age distribution here. So the tumors located in the telencephalon were actually mostly found in younger patients, whereas the older patient mostly had tumors located in the mesencephalon or myoencephalon. If you look at the survival data here, you can also see that there are differences between the different locations. And I'll get back to that later. If we group it in the one that are more located in the upper part of the brainstem or in the lower part of the brainstem, you can actually divide two groups which have significant differences in survival. So the ones that are located in the mesencephalon or mesencephalon, so kind of anatomically in the middle, actually had a significantly better survival than if you go up or downward in the anatomical regions. As I said before, it's a heterogeneous tumor, also not only by location, but also by radiographic presentation. And if you see here, those are all 4 different K27M tumors. Some of you, for example, with patient A would have said it rather looks like a classic glioma with a cystic component, more like a glioblastoma, while in patient C is more a diffuse infiltrating, typical pontine glioma with more flare than a T1 contrast enhancement. Overall, we can find contrast enhancement in 77% of tumors, and only a small proportion of tumors had actually no contrast enhancement. Most of the patients actually presented as a primary symptom with hydrocephalus. Other symptoms were seizures, hemiparesis, and various other different focal neurological deficits. But hydrocephalus was actually the most unifying presenting symptom. Edema size varied quite strongly, although this is not a tumor that was characterized by quite a large disproportional edema. If you look at the survival, the only factor that actually showed a significant impact here on progression was the cystic and non-cystic component, although the cystic component was actually only present in a smaller fraction of tumors. Coming next to the second part is the surgical part. We had just an analysis of how these tumors were approached. 20% used a biopsy here. Some had an open biopsy approach, and most of the tumors were actually approached by the convexity. 20% of surgeries used 5-ALA. Most of them used neuronavigation, and intraoperative neuromonitoring was pretty much used in about a third of cases. Coming now to the Karnofsky performance status of these patients. Preoperatively, most of the patients were in good shape. Around a quarter of patients had a Karnofsky below 70, and this was actually something that we further analyzed into the progression and overall survival. And here, if we go for a cutoff for patients who are doing quite well, we actually see that the patients above an 80 Karnofsky had a much longer overall survival, with a median overall survival of approximately 2 years, although the progression-free survival was the same. If we go for post-operative Karnofsky, which declined in only a fraction of patients, we see the same thing. Again, significantly longer overall survival, and this is something that has to be discussed later on. First of all, it has to be discussed if these patients, if they have the same progression-free survival, if the patients only didn't get a second-line treatment, or if they the treatment kind of tolerated this progression longer than in the patients who started out with a lower Karnofsky scale. So overall, for the survival, Karnofsky was a very strong predictor for a good or worse outcome. Now going into the resection part, and here, as I said before, most of the patients underwent biopsy, open or, for example, stereotactic biopsy. 14% gross total resection was achieved, and most of the patients where there was an open resection actually had a subtotal resection, probably due to the eloquent location close to the brainstem. And if we look here for the progression-free survival and the overall survival, we actually do not see a difference at all. And this was something that also has to be discussed when looking at the radiographics. So maybe this is something that is very hard to evaluate in these tumors. If you have tumors that have a large flare, they are diffusely infiltrating into eloquent areas, it's also hard to evaluate if you really got a gross total resection, or if a gross total resection at all would be possible in these tumors. And in most of the cases, as you can see, if they were just biopsied, most of the cases, a gross total resection was probably never possible. And in the cases where a subtotal resection was performed, the gross total resection was probably not feasible. So coming from this, actually, we do not see a benefit from a gross total resection, although the subgroup is small. If we look at the length of the ICU stay and also the deficits, we do see that patients who had a resection had an increased prevalence of deficits, and there's also a certain fraction of patients who had a very, very prolonged stay at the intensive care unit. So the question that we have to ask is the benefit of the resection or tumor cell reduction wasted due to the clinical decline? Meaning that once we try to resect aggressively, we might produce deficits that in the long term pretty much destroys our effect of the surgical resection. If we look then at the molecular pathology, and we here saw that actually the status of the ATRX, so if it's lost or if it's retained, is a independent prognostic factor for overall survival and progression-free survival. So in most of the IDH wild type tumors, we do see that the ATRX is retained. And our suggestion is that if the ATRX is retained, we do actually see a more aggressive course. We try to look further into the molecular data coming from the Illumina arrays of the methylation arrays. We do see a trend that there are more alterations in the ATRX retaining groups. However, this looks mostly quite balanced. However, if we look at the children data, there's also a certain percentage of K27M gliomas that have an ATRX retention, but the frequency was much lower in the pediatric counterpart. So in terms of molecular alterations, we actually now have a closer look how these patients are in terms of the ATRX status. And if they have an ATRX retention, we even might treat them more aggressively, or we switch to a second-line chemotherapy if the first line fails. And a small hint or a small reference here also to a talk that was presented by Dr. Philbin from the Dana-Farber Cancer Institute at SNO in Vancouver. She also talked about K27M diffuse midline gliomas here, and she saw that there's also different cellular backgrounds in different locations and according to age. So she discussed that going from pediatric to adult, you see a shift in mesenchymal-like cells, so that increases, the mesenchymal component increases with age. While in the anatomical distribution, you see more OPC-like cells in the upper part of the brainstem, while in the pons and mid part of the brainstem, you have more pre-OPC-like cells. So something that we actually we saw in our data with the age and the location and also the biological aggressiveness might correlate to these cellular states that are being investigated in the pediatric subpopulation right now. So what's the take-home message? If you have patients who present with a K27M tumor, it is also important to have a look at the KPS, because the KPS and the locations were actually a strong correlator for overall survival. What did not correlate with overall survival is the extent of resection, the residual tumor volume, or the initial tumor volume. And that leads to the question we are here to discuss, is that does aggressive surgical resection in these tumors make sense? Is it a risk or benefit? And according to our data, it is rather a risk because of secondary deterioration in Karnofsky, and maybe you destroy your benefit, your tumor reduction benefit, due to new neurological deficits. So the study was also mainly done by Alice Rieber, and I would like to thank all the collaborators, and I'm happy to answer questions.
Thank you, Malte, for the great presentation. Please use the Q&A box to put some questions in. We'd like to ask Malte right away. This is not the case yet, so I would like to start with a question. So how you do it now? So you do a tumor, a patient comes with a hydrocephalus, you see a near midline tumor. So what's your approach to that case now?
So if he has a clear hydrocephalus, we try to do an EVT. If possible, in the same session, we try to get a biopsy. We also we are performing a lot of CSF molecular analysis right now. We use a nanopore sequencing from CSF, try to do targeted NGS for that. And if we have a tumor where we feel that they could, I mean, they are in the lower age range, they are close to the midline, there is a high suspicion for K27M glioma, we try to get a biopsy during the EVT, or we try to get CSF. And if we can confirm it in the beginning, we do not plan for aggressive resection anymore. So only if the resection can result into amelioration of symptoms or midline shift or whatsoever. But our goal is only to surgically treat the symptoms so that the patient can start with radio chemo as soon as possible.
Would you mandate for a biopsy first strategy in cases where you suspect it? Like if you have no hydrocephalus?
If the risk for an open surgery and tumor reduction with a neurological benefit is high, yes.
Okay. Because we know these cases, and I actually recently did one of those, intraventricular tumor with thalamic parts. No medical history so far. I had the impression it might be a glioma intraoperatively, so I did a frozen section. And the frozen section came back as it might be a glioma. So knowing those data since we were involved, I stopped. I left something behind. And in the end, now it's a melanoma metastasis.
Well, we found that actually the intraoperative cryosection are not very reliable. So in those cases, actually, I think a biopsy would help if you think that surgery, if it really would dictate your surgical resection. Although it's quite interesting that a melanoma is then kind of mixed up with the glioma.
It came back as a pleomorphic tumor, might as well be a glioma. Frozen sections do that all the time. You know, we know that if we ask for, is it a metastasis or a glioma or a meningioma, sometimes it comes back as it might be all of those. So that's the problem. It's not blaming the pathologist, because we know that frozen section is terribly difficult. Do you do anything different in terms of pre-op imaging?
No.
Do you have any ideas or thoughts on that? Spectroscopy, PET, anything you could?
I rather would, I mean, the case you're just presenting, this is a good example of how molecular pathology could influence your surgical strategy. So if you could perform nanopore sequencing on those samples right away, this I think in the near future will be possible to get actually a molecular diagnosis as a cryosection. This would I think help you much more in these cases. And in terms of imaging, I mean, we do everything to sort out the risk, the intraoperative risk. So you would recommend for DTI, you would recommend also in these cases where are the long fiber tracts pushed into which direction. And then also, of course, I think neuromonitoring is quite helpful in these cases.
Still no questions in the Q&A, so please come forward, ask some questions. If not, we'll have some more discussion, I think, afterwards. So we'll move on to our second speaker. We're happy to introduce and welcome Niklas Grassl from Mannheim, Germany, and from the German Cancer Research Center in Heidelberg. He's jumping in at very short notice for Katharina Sam, who has a very, very good reason not to be here, since she's expecting a baby really soon. Niklas Grassl studied mathematics and medicine in Munich. It's quite a combination. And collected his first research experiences at the Max Planck Institute of Biochemistry in Martinsried. In 2019, he joined the Department of Neurology in Mannheim with Michael Platten's group, and accordingly to that, the German Cancer Research Center in Heidelberg. And his research focus also is immunotherapy of diffuse midline gliomas and cancer evolution. He will now talk to us about a long peptide vaccine targeting the drivers of K27 mutated gliomas, since this group has published some very, very interesting data on this very recently. Niklas, we're happy to have you here and delighted to hear your talk. Please unmute.
Yes, thank you so much. I hope you can hear me now. So I'm very honored that I may give you this presentation on our peptide vaccine targeting the clonal driver mutation in diffuse midline glioma. And I don't have any conflicts of interest, and I will just jump right into it. As we've just heard, the histone H3 mutation is an interesting molecular target, because it is both clonal, preserved in relapse, and it's a driver of malignancy because it leads to a global deregulation of gene expression and a significant change in the epigenetic landscape of these tumors. We wondered, because our lab is specialized on immunotherapy, whether we could design a peptide vaccine targeting mutant H3. Now, the common way of a cancer vaccine is to elicit cell-dependent cytotoxicity mediated by CD8 T cells. And since CD8 T cells usually respond to MHC class 1, one uses short peptides of around 10 amino acids in length, because the peptides presented on MHC class 1 are around 10 amino acids in length. However, other labs and our labs have recently shown that CD4 T cells, in particular intratumoral myeloid cells, are very important both for eliciting but also for maintaining immune responses against neoepitopes. So we wanted to, rather than taking a short peptide, use a long peptide vaccine that would allow for both internal processing, and then presentation on MHC class 1, but also on MHC class 2. And prior to testing this long peptide vaccine, so it was a peptide vaccine of 27 amino acids in length, harboring the H3k27M mutation in a central position. Prior to testing this peptide vaccine, we first wanted to make sure that mutant H3 is indeed presented on the surface of diffuse midline glioma cells. We did this with a so-called proximity ligation assay, and I will quickly go through the principle of this assay. So two molecular targets, in our case, HLA-DR, which is an MHC class 2 molecule, and mutant H3. When they're in close proximity, you can both target them by an antibody, and only if these two antibodies are in close proximity, a circularizable DNA probe can close this loop, and subsequently an in situ rolling circle PCR can kick off, and the elongating DNA strand can then be visualized by oligo marker that is labeled with a fluorescent dye. In our case, we used a red dye, and the red spots that you can see on the right indicate that the mutant H3 is indeed presented on MHC class 2, because only in that case the PCR takes off and you can get this visual response. So indeed, mutant H3 is not just present in the tumor, but it is also presented on MHC class 2 on the tumor surface. Next, we tested our long and also a short peptide vaccine in an MHC humanized mouse model of H3k27M expressing flank tumors, and we could detect interferon gamma ELISpot responses both to the long and the short peptide, but the long peptide had a particularly pronounced response with T cells. Also, we could show that our long peptide vaccine controls tumor growth in these mice, and that the post-vaccine tumor tissue was infiltrated with CD4 positive intratumoral lymphocytes. Now, this was all done in mice, and now I'm presenting the first in human data from 8 patients that were treated with this long peptide vaccine for recurrent diffuse midline glioma. All 8 patients had undergone standard of care therapy. Most of them were biopsied, some of them resected. They had all undergone radiation and alkylating chemotherapy. Furthermore, they all had a rather good clinical status with a Karnofsky performance index of 70 or higher, and they all had unequivocal disease progression. We administered the vaccine every 2 weeks by subcutaneous injections and applied topical imiquimod, which is a toll-like receptor 4 modulator, in order to stimulate immune responses. Initially, the vaccine was given bi-weekly for 4 vaccinations, followed by monthly administration for 3 vaccinations, and then 3 months thereafter. Concurrent to this therapy, we collected PBMCs, so T cells from the blood, evaluated the patients clinically, and also took CSF samples, and of course, took MRI measures every 3 months. 5 out of the 8 patients received concurrent therapy with anti-PD-1 antibodies. And yeah, you can see in this swimmer plot that the responses were rather heterogeneous. I will start by talking about the adverse events that we observed. We only observed 1 adverse event that was attributable to the vaccine, which was injection site reactions. All the other minor adverse events were either attributed to prior chemotherapy or to disease progression. 5 out of the 8 patients had immune responses that were H3k27M specific. The median time to first detectable immune response, as judged by interferon gamma ELISpot responses, was 4 weeks corresponding to 2 vaccinations. And you can see that the time was rather heterogeneous. So one patient also just had his first response after 10 weeks of vaccinations. And fortunately, the responses were durable. So on the right, you can see that patient ID1 had an immune response for a time period of more than 2 years. Looking at the clinical outcome, the progression-free survival was 6.2 months in our patient cohort, and the median overall survival 12.8 months, with one patient being still alive and one patient going into sustained complete remission for more than 30 months now. Looking at the radiographic response, all the 5 patients that had detectable immune responses had at least transient regression of their tumor growth. And you can see that one patient went into really sustained complete remission, and I would like to share the MRI of this patient. At baseline, you can see that there is a contrast-enhancing lesion in the thalamus that grew substantially by week 10, and by week 34, this contrast-enhancing lesion wasn't detectable anymore. This pseudoprogression is a phenomenon we already know from the NOAA-16 trial, which is a similar peptide vaccine trial against IDH1 for astrocytoma. And in this trial, we also had sample from a re-resection of one of these patients that had such a pseudoprogression, and we could show that this contrast enhancement corresponds to a intratumoral infiltration with lymphocytes, which is what we would desire with our peptide vaccine. Now, trying to differentiate which patients would respond best to our therapy, we developed an automated segmentation algorithm to quantify the proximity ligation assay spots. So you remember the assay that I explained in the beginning, and we could show that a high spot count in this proximity ligation assay corresponded to a high expression of HLA-DR, which is the MHC class II protein. And you can remarkably see that patient ID1 and patient ID8, the patients with the 2 most favorable outcomes, had top scores both for HLA-DR, but also for the PLA spot count. Next, we wondered whether how this vaccination is mediated, and we realized that anti-MHC class I antibodies, but anti-MHC class II, but not anti-MHC class I antibodies, could suppress the interferon, the ELISpot response signal when we re-stimulated PBMCs from the peripheral blood with the mutant and the wild-type peptide vaccine. And this indicates that it is indeed the presentation on MHC class II which mediates the effect, and therefore the T-cell responses that we observed are CD4 T-cell dominated and not CD8 T-cell dominated. This is also apparent when you look at the FAX plot. So here on the top, in the top row, CD4 T-cells were stimulated with either wild-type or mutant vaccine. And you can appreciate that upon stimulation with the mutant peptide, you have an intracellular cytokine staining with TNF-alpha and interferon gamma. And this cannot be observed for CD8 T cells, both for wild type or for stimulation with the mutant peptide. We also wanted to characterize the T cell responses a bit further. This was mainly work done by Tamara Boschert, Ed Green, and John Lindner. And their paper is about to be published in Science Advances. So they took PBMCs, re-stimulated them with the mutant peptide, then subjected them to T-cell receptor sequencing, and looked specifically at those PBMCs that expanded upon stimulation with the mutant peptide. Subsequently, they tested these TCR using a Jurkat reporter cell line, to determine whether they were indeed reactive to mutant H3. And in this way, Tamara could identify 34 unique H3k27M reactive T cells in patient ID1, the patient that responded particularly well. And she saw a particularly strong signal for HLA-DRB1 1302 and designed this model of how the peptide is presented on this HLA molecule. With this data, we also took a look back at the CSF and the PBMCs from patient ID1 that responded so particularly well. And we could show that concurrent to the pseudoprogression that you saw on the MRI, PBMCs expanded. This is the top 10 TCR clonotypes. And among those top 10 TCR clonotypes, we could detect 3 of these also in the CSF of this patient, and 7 of these top 10 TCR clonotypes were indeed reactive against mutant H3 as judged by this Jurkat reporter cell line. We also looked at the T cell phenotype and could show that these were T cell central memory T cells, indicating that probably the T cells were trained in the periphery and then migrated to the CSF, which is reassuring. So with this, I would like to conclude that H3k27M VAC is well tolerated by patients with diffuse midline glioma. It induces CD4 T cell dominated mutation-specific responses across multiple HLA allelotypes. The median overall survival was 12.8 months in this 8-patient cohort. And encouragingly, there was 1 patient who went into sustained complete remission for more than 30 months upon initial pseudoprogression. And I would finally like to draw your attention to the INTERCEPT H3 trial, which is a now recruiting trial for patients with newly diagnosed diffuse midline glioma that receive our peptide vaccine in combination with standard of care radiotherapy. And after completion of radiotherapy, they receive the vaccine in combination with atezolizumab. And yeah, I hope that we can report on the results of the trial sometime in the future. At the moment, we have 3 patients that were already recruited, and overall, it'll be 15 patients that we will enroll. And feel free, if you have a patient with a diffuse midline glioma that is newly diagnosed, to reach out to us or also to one of the other trial sites across Germany. It's 8 trial sites that are participating, and we would be very glad to enable patients to receive this therapy. With this, I would like to thank the entire team at the CCU Neuroimmunology and Brain Tumor Immunology here at the DKFZ, and in particular, Katharina Sam, who really designed this project and did all the mouse work prior to testing in humans, and Michael Platten, the head of our department. Thank you for your attention, and I'm happy to hear your questions.
Thank you, Niklas, for the amazing talk, and thank you for making some very difficult parts of immunology understandable for neurosurgeons. I have to disclose that I probably did not understand each and everything, but I had the idea of understanding most of that very technical and very deep into theory parts of your work. One question straight ahead for your study proposal of the INTERCEPT study. Mm-hmm. As an Austrian, what's the next center in terms of distance?
I think it'll be Munich or Tübingen.
Munich is closer to Innsbruck. So
okay. Yeah, Munich.
Who's in charge in Munich?
I would have to.
It's okay. We'll figure it out. But that's just
not open yet in Munich. I can say that for sure.
It's just my personal interest. So we have some questions in the chat, but they are mostly not related to your talk. So we'll work with those afterwards.
Maybe I can ask a question to your talk.
Yes, please.
So how do you explain that the anti-MHC class 1 actually is resulting in a better immune response?
That's a good question. So you're referring to this plot.
Experiments where you had where you try to dissect if it's rather the CD4 or CD8, and compared to your control, the anti-MHC class 1 did much better in terms of response.
Yeah. So I'm not so this is all in vitro. I'm not 100% prepared to explain why you see a stronger ELISpot response upon suppression of MHC class 1 signal. So I've discussed with different immunologists what their thoughts on this were.
It's probably a tough question to answer, though. But I was just curious about it. If there is certain actually a tolerizing CD8 response, something like that. I mean, because in the end, your CD4s, you probably see that they're responsible for the interferon gamma production. But
yes.
in the end, the CD4s are probably just supporting the cytotoxic response. So what you're missing is, or what your vaccine does, it supports the mediator of immune response.
I agree.
So that was just an interesting thing. And another question for your clinical data is, how did you determine, or what was the timing? When do you use anti-PD-1, or what was the rationale when to bring in the anti-PD-1?
Thanks. Yeah, that's an excellent question, and I think I missed that. We did not see an apparent association between the treatment with anti-PD-1 and the immune response, which is also an interesting question, whether there is some synergism, which is also part of the INTERCEPT trial concept. So in this cohort, it was basically physician's choice, and there was no clear.
But you didn't see any clear effect on that, or?
So we saw one effect, which was that the overall response in our ELISpot assays was a bit ramped up upon the anti-PD-1 therapy. But since we tested for the specificity of the immune response against mutant H3 as compared to wild type, there was no significant association between anti-PD-1 and the specificity of the immune response. So we had responders and non-responders as judged by ELISpot in both groups. And
okay. And is there any rationale to work with radiotherapy kind of in your trials? I mean, radiotherapy has been shown to induce HLA class 2 expression in the tumor microenvironment as by local destruction, and this would something that would actually help your immune response, no?
I agree. Yeah. So we actually are having a couple of projects in mice where we investigate whether there is a synergism, or whether you can turn immunologically silent tumors hotter, so to speak, by radiotherapy. And I, for my part, hope that this will boost the vaccination concept, that we have it in combination with radiotherapy. And also, I think it's important that the INTERCEPT trial allows for more time of the immune response to actually show an effect, because since some of the patients died rather early, there was probably simply not enough time in this patient with recurrent disease to have a meaningful benefit of the therapy. And this will be hopefully different by treating patients with newly diagnosed diffuse midline glioma. And that's why we also incorporated the vaccines right at the start of the radiation, and going right through and giving the atezolizumab in combination.
But you switched from anti-PD-1 to anti-PD-L1, right? In the trial.
So that's, yeah. So in INTERCEPT is atezolizumab that we are administering.
I'd like to take off on the radiotherapy part, because we know that radiotherapy in those tumors is helping a little bit, but not a lot. And most of the centers are using the same treatment regimen as in the glioblastoma for those patients as a lack of other things. So we rely on concomitant radiochemotherapy, and then we use temozolomide because up to now, out of studies, there's nothing else. And in the preparation for this webinar, I found some also theoretical papers and lab papers about radiosensitizing those tumors, mainly in a pediatric population, by using, for example, osimertinib. Do you have any experience with that, with radiotherapy and radiosensitizing those tumors before you treat them with a vaccine?
We don't have any data on that. I think it's an interesting approach, especially because the treatment options are limited at the moment. I guess the hot the hot topic and the new kid on the block is the action trial and on 201, and we'll hopefully have the results soon. I think this is especially especially important because radiotherapy really seems to be one of the best treatment options that we have, though we can't be satisfied with the results.
Malte, how do you treat those patients right now after surgery?
Sorry. As you mentioned, there's not much in the literature that you really have a grasp on. So we treat them with a Stupp. But it's quite frustrating actually, because although I presented that the course might be quite heterogeneous, a large subgroup of the patients have a very, very aggressive disease course.
There's one question in the Q&A that's for, I'd say that's for Niklas, a question by Nikad. So what's the best treatment in the recurrent situation?
So the honest answer is I don't know. I can say what we usually do in Mannheim. We either consider whether patients are eligible for re-radiation, but because of the midline location, this is sometimes not a good option, and we usually just do re-irradiation if 1 year has passed, which is often not the case when people recur. So in the past, we've treated some of the patients with our vaccine as part of a compassionate use program that was required by the Paul-Ehrlich Institute to get the INTERCEPT trial started. And that's the results that I just presented you. So there is this option still. And if you have a patient with recurrent disease that would be interested in getting the vaccine, feel free to reach out, and we're happy to advise on that or give advice on that. And apart from that, we still do panel sequencing of these tumors and look for overexpression of M-phosphor scores and potentially consider temsirolimus in that case. Or if we find a suitable basket trial or a target that looks promising, we would apply at the insurance company whether they would cover the costs for such a therapy.
There's another question that came up that fits well to any neuro-oncological disease right now. How do you diagnose pseudoprogression, recurrent, or radiation necrosis? So you showed us the images of the response and this IRANO according progression, pseudoprogression that disappears. What's your standard protocol in those patients to differentiate between pseudoprogression and else and real progression?
This is also a very tough question. I think the honest answer is that we are still lacking the data, especially in these rare entities. So basically, we use the IRANO criteria, but I think that the criteria are the best we have, but I think we all agree that they are not 100% accurate in differentiating pseudoprogression from true progression.
In terms of IRANO, I think, sorry. Sorry to
No,
interrupt.
I think I was just mentioning that it was interesting that from the NOAA 16 trial, we had this case of patients that got re-resected because people thought this is a progression, and it turned out that it was a lymphocytic infiltrate. But this is really all I can say.
Still an unresolved issue, because if you look at iRANO, the critical comment is allowed that it's basically RANO, but 12 weeks delayed. That's the biggest difference.
But the question is, in the
Yes?
end, if it grows, I mean, we try to, of course, have a sufficient distance between the finishing of the radiotherapy and the first MRI, and then we can do a diffusion MRI, which sometimes help. But in the end, if it grows like a tumor or it grows like a radionecrosis, it makes symptoms. It has edema, and in the end, sometimes we reoperate also to get an histology on it, because then it's easier to get Avastin, which has a good effect in that case. So,
speaking of which, there's another question for you, Malte. So Stefano is asking, is stereotactic biopsy always preferable for those tumors?
not always, but in most of these cases. So we usually do varioguide on tumors that are accessible via the convexity in not too much depth. If you have a certain error margin that is possible or it can be tolerated, but once you have to go through structures that are close to the brainstem or thalamus, we always go for stereotactic biopsy.
We don't have any more questions. I'd like to thank you both for your amazing talks and for the discussion. I think it's very enlightening that there's some prospects for those devastating tumors in the future to come. Thank you for your time and your great talks, and thank you all participants for listening and the discussion. And I'm looking forward to see you on the next webinar. To all, I can't speak anymore before Christmas. I'd like to wish you all a very cheerful holiday season, some nice time with your families, and looking forward to see you all next year again. Thank you very much.
Thank you. Bye-bye.
Thanks. Bye.